Welcome to a Germ's Journey discussion. I'm Rob Watson. Over a series of 3 conversations, a group of practitioners and advocates of community-focused health and community media are coming together to talk about the challenge of public health messages and information in Leicester. Hello and welcome to a Germ's Journey discussion. Our first discussion is going to examine the challenge of community-focused communication compared with mainstream approaches to public information. Many public authorities and government advisors have recommended using what's known as the Behaviorist Model that seeks to nudge people into behaving in a specific and approved way. In the behaviourist approach, the focus is often placed on instruction and routine. The belief is that our behaviour can be changed with a simple nudge. If a falling infection rate was the goal of behavioural communications, however, then in Leicester it didn't seem to work very well. Leicester has had the longest continuous lockdown of anywhere in Europe, so clearly there are many lessons that need to be learned. Joining me to examine how we can improve our public health communications is Mukesh Barot from Healthwatch Leicester and Leicestershire, Dr. Charan Johal from Kohinoor Radio, and Dr. Charlotte Hilton from Hilton Health Consultancy. Thanks for being here today, and I'm sure we'll have a very engaging conversation. Can I start with a quick fire question for each of you? Can you tell us a little bit about the work that you do? And do you think we've done a good job engaging with people in Leicester about the COVID-19 pandemic? We can start off with Mukesh. Tell us a little bit about yourself and tell us a bit about the headline bullet points of how you think we've done in terms of our communications approach.
So Healthwatch Leicester and Leicestershire, we are the champion for the public voice or the patient voice to make sure that any issues, experiences, gaps, challenges are articulated to service providers across health and social care. We are there to make sure that anything that we identify through conversations like this are fed back into service design and planning. So ideally, the services are responding to people's needs. So what we found is that the pandemic hit hard very suddenly. It was unprecedented. Nobody was prepared, either in terms of service providers or in the community. It just hasn't happened before on this global stage. So what we found was that there was a bit of initial panic. People were trying to figure out how to adapt in terms of communication. Healthwatch, about 80% of our work is to engage and involve. And obviously we can do that with lockdown. So we had to identify new models of engagement through social media, through online meetings. And it was a great learning curve for public authorities as well as members of the community. And to be honest, it's still a learning curve. However, whilst we have made attempts to move beyond surveys and paper-based, snap surveys and online surveys and things, we still feel that there are many people out there who are not used to working with new technology. So what the challenge is, how do we reach those? And how do we reach those communities who do have technology, but are perhaps not used to mainstream software like Microsoft Teams? They might be using alternative, more grassroots models. So what Healthwatch is doing is we're embarking on different approaches through volunteers, through members of the public. BME Connect is one of our initiatives, working directly to have that dialogue of co-production with members of the community rather than presuming what they want.
Cool, thank you. I'm going to bring in Charlotte at this point. Tell us a little bit about what you do and how you feel that the communications process or model or practices have gone over the last 12 months.
So I'm a psychologist by profession, and as a freelance consultant, I'm often involved in a diversity of work with a number of organisations and individuals, but predominantly the NHS. And most of the time, actually, interestingly, my work is around supporting general practice with a range of different things, and that has included support both practically and emotionally for responding to the huge changes that COVID-19 brought on routine practice and staff's ability to be able to deliver routine care that was safe and efficient, and also the rollout of the COVID vaccine. So I think a lot of the work that I've been involved in recently is probably very relevant to some of the discussions I anticipate we'll have today, and especially in terms of how right have we got the public health messaging to the public. And I think whilst there are some examples of what in psychological terms would describe as probably evidence-based effective approaches to public health messaging, there's certainly several examples of where that's perhaps fallen quite short of what we know would be helpful messages to help influence people's behaviour. And fundamentally, a lot of the restrictions that COVID-19 has brought have been linked to the science and psychology of behaviour change. So there's an awful lot that psychology can offer in terms of helping behaviour change and helping influence COVID safe behaviours, for example, within the wake of a global pandemic.
Charan, you run a community radio station. Tell us a little bit about what you do there, and tell us a little bit about what you feel the communications challenges have been over the last 12 months.
Right, I'm responsible for the day-to-day operation of a community radio station, serving the Punjabi-speaking population here in Leicester. It's a very broad remit covering areas such as news, current affairs, information, education, health, sport. Now, the list is endless, basically everything to do with day-to-day life. Here in Leicester, we have approximately 120,000 people, based on the last census, who can either speak or understand Punjabi. So the number of people we can get out to is quite phenomenal. Right across the city and the county. Personally, I've been involved in community affairs and community organisations for the Punjabi community since the early 90s. So we've got a fair bit of a background and experience working with the people, understanding the needs of the people, and also how we can get messages across to them and involve them in all activities going forward. I feel the overall pandemic for the Asians here, and especially the Punjabi people, hasn't gone down too well. And it's largely because of I would say, the poor level of communication by the local authorities and the health authorities towards the different communities. There's been a lot of mainstream media, but pertinent, relevant information explaining what the COVID was and what people needed to do really wasn't there. What we found as a consequence, we were having to train our people up, train new presenters up who were bilingual, bearing in mind a lot of our presenters were not very proficient in the English language because we are a Punjabi speaking radio station. We had to get new presenters in who could speak both Punjabi and English to glean information from mainstream media to pass on in an appropriately cultural language. And that has been quite an exercise for us. Going forward, I think we've learned a lot, and hopefully throughout the next hour or so, we can pass on some information which will help the community going forward.
That really nicely brings me to a question I've got for each of you, and feel free to jump in as required. But I'll start with Mukesh and kind of work around again. What do you think the assumptions are that have driven we call it the mainstream model of communications? We've got to be quite careful about using that phrase because it's used a lot. But generally it means BBC, large-scale commercial communications, newspapers, that kind of thing, popular, generally available. What do you think the assumptions are that have driven that form of that form of engagement, as opposed to exploring maybe some alternative, and we'll get into that later, but as opposed to alternative forms of community engaged media?
I guess Charan, you sort of touched on the subject of mainstream communications not connecting with certain communities, whether they are ethnic minorities or whether they're disability. The issue is that we're talking about part of a area where communications departments or individuals have undergone marketing communications training at a university or within an organization. And their model of thinking is very much about, color schemes, font sizes, corporate standards, that kind of thing. Their thinking is very much inwards towards the organization. It's a corporate way of thinking. So, for example, if you have a NHS or social care organization with a large diverse community on its doorstep, I would imagine that they haven't connected with an organization across the road. So this is the issue. Now, when you get a communications expert and you say to them, look, when we talk about communications, the messenger is as important as the message. So if we were talking about International Women's Week and we were trying to promote things for women, if the messenger on the communication, whether it's a radio, television, or posters, was a male presenter, it's not going to link as well with the female population as would a female presenter to a female audience. And the same would apply for young people having an older presenter. So when we talk about a target group, like let's say, for example, disability or ethnic minorities, it's always good to have somebody who has that same lived experience or background knowledge to be able to understand, and also then for the communities to be able to say, okay, I can relate to that person because they're from my community. And that opens an inroad. Now, I'm not saying that that's always going to work because it depends on the individual and the way they practice, but it is a starting point. So I think that's one thing. I think the other thing is that when we talk about the COVID lesson, there was a lot of skepticism within the BME community, in my experience anyway, that the powers that be, whether it's governments, local authorities, the NHS, people in the community were thinking, hang on a minute, why are BME communities being affected more than anybody else? So, that talk in the community, that grapevine about, hang on a minute, have you heard this? It's not only members of the community, it's doctors and nurses as well, in the NHS who are saying we're not going to have a vaccine. So that domino effect was circling around. And then you get all these stories about, well, maybe there's a conspiracy here. Is this an experiment? So, the message was coming from the government, you must take the vaccine, but at the same time, the public were hesitant of the government's intentions in the first place. So, trying to get that co-production model with community groups and community media to say, well, actually, let the community decide what the issues are and let them find out what the way forward is, as opposed to this government message, which actually might be the cause of some of the skepticism in the first place.
Charlotte, that really dovetails into a question I want to ask you, which is about assumptions. You work closely with people in the health services. What in your experience, what are the kind of assumptions about communication? Because they're not trained communications experts, doctors, medical professors, consultants, general managers. They're not communications experts. But what do you think the kind of assumption is? And actually, that's a phrase I've started to call not mainstream media, but assumption-driven media. What is it that they're taught to do? What is it that they think media and communication is?
I think in more broad terms, it's perhaps helpful just to I guess to remind us rather than tell us anything new, that a common assumption that we all have is that if folks don't do something, it's typically as a result of a lack of knowledge, that people don't know, and that's why they're behaving in a certain way. So even as a helping profession, as a clinician, as a GP, as a nurse, as the whole range of health and social care practitioners, often fall into the trap of spending that precious time that we've got with people, filling the space with educating, because of course it must be that, you know, all of us are not following some of the behaviors that we know are good for us, in terms of we pretty much all know foods that are healthier for us versus not. We pretty much know that, you know, selecting alcohol as a drink rather than something without alcohol would be a poorer choice. And that we should be moving more often than a lot of us are, you know, taking regular exercise, self-care, all that good stuff. And yet we don't always consistently do that. So that tells us that actually behavior is linked to something much more complex than simply either knowing or not knowing. And for me, I think this does transfer into the health and social care professions as well, that we can assume, and certainly the media as well can assume, that if we simply tell them, then they will do. But actually there is a wealth of evidence, and from our own personal experience in a way that I've just described, that tells us that that's simply just not the case, that our knowledge predicts our behavior. So we have to look at things in a more complex way. And I echo what we've just heard about the importance of relatedness in particular, and also a more of a co-production approach to trying to jointly problem solve, because it's through that approach, rather than assuming that we know and simply telling, that actually we're probably going to generate messages that are much more tailored and suitable to the population that we want to help and support.
Charan, you've been at the sharp end of promoting these messages. We've all done this, but in running a radio station, you've got a very specific platform. What engagement have you had with public health managers, communications experts, and what assumptions have they based what they expect from you? Has that been a reciprocal relationship?
Not really. Quite honestly, the relationship has been very poor. The amount of engagement we've had has been very poor, and the information we have received has been very simplistic. It's very simplistic in the sense that, like Charlotte has mentioned and Mukesh, that the assumptions are being made that, I'd say like one shoe fits all. There's certain information given out by the health authorities without real consideration who the end, my opinion, who the end receiver is. Is that person going to understand the information? Is it enough? There's information going out, things like, wash your hands, without really emphasizing to people who may not understand what the need is to wash their hands. There needs to be more, maybe more in terms of promoting behavior rather than just expecting that if we tell people to wash hands, they will wash their hands. There needs to be explanation behind the message that's going out rather than explicit messages. I think it's very broad, very simplistic, the messages that were coming out. But I think more disturbing was the lack of engagement. Anything that we've put out there as a message has been what our own team has actually gleaned from across the internet or from BBC Radio, which I think at times of a pandemic is very poor.
Yeah, there was no concerted effort or central process. People were often, with community radio stations, in my experience, were kind of left to their own devices. They were
Absolutely.
told what you shouldn't do and that they'd be policed. Ofcom were very clear about policing what kind of information could be broadcast, particularly kind of related to things like 5G and misinformation, and they've been very strict with that. But there wasn't the other side of it, of a public resource that was made available for people to use. Mukesh, in terms of this as a kind of, we might be splitting hairs. I think that's our job here in over this discussion. Just in terms of it's in terms of the difference between instruction and guidance seems to me, actually it's a simple, they're two related phrases, but there's a huge gulf in terms of how do you plan what Healthwatch does to encourage the health system that you interact with to recognise the difference between instruction and guidance.
Well, we were there back in February last year, where the conversation in the health system was very much about translations. And I kind of raised the issue and said, well, translations, you're talking about quite a few generations since the main sort of BME populations, arrived in the UK. And, in a lot of the cases, including myself, I don't read and write my own language. My English is the first language in the family. And there are still assumptions and opinions within public services that, we'll do a poster with some Punjabi and Urdu and Gujarati and, XYZ. And so I raised the point last February and said, look, number one, it's going to be an issue about who can actually read and write their own languages. Number two, often when you see these posters or flyers, the font size is so small, they're trying to cram 7 or 8 languages onto one poster. The color schemes are all wrong. So, those people that can read and write their language are struggling to read a red font with a green background, so that's even before we get to the stage of, do these communications leads know where to distribute the information once it's actually printed? Especially during lockdown, you're not going to be able to deliver boxes of, leaflets and flyers. And so the voluntary and community sector were not on the databases, in terms of getting information out. You've got, even in terms of main providers, pharmacies and, doctor surgeries with LED screens, that you can have messages in different languages and, spinning around and rotating. But even today, as we speak, those messages are not being utilized on that information technology that we have. So I guess the issue that I raised last February was, look, I think what would be better and easier to update is video files, and in terms of those video files, I think if you use people from the target community as the presenters of those messages, it's going to have more of an impact than somebody from Department of Health or somebody from the government. And as far as I'm aware, the government are still playing around with trying to get famous BME actors and actresses, to convey messages. Now, what I'm saying is, well, actually, use local people. I was one of those people, even though I work within the healthcare, health and social care system, I was hesitant to take the vaccine because I was in the same way dubious about, what's going on and what's the longer term impact? Has this been rushed through? And actually, it was my daughter who said to me, Dad, it's not just about you, it's about your children as well. So if you're around for longer, think of your children, and that's the thing that twisted it for me. And I was fine. Then I talked to one of the counsellors who's South Asian as well. And he says, yeah, I had the vaccine. There was no problem at all. So that word of mouth is the thing that makes a difference. Now, if we can capture that on video as people's stories and just circulate that, as MP4 files or whatever it is, or through discussions like this, I think that's the thing that will make the difference. People's voices, lived experience, and also trying to get both perspectives, trying to get the perspective from the GPs and the health professionals, as well as the communities. And like you were saying, Charan, is, let's get these people on the radio stations. Let's get these people to talk openly about the issues and challenges and put your hands up where you're not getting it right, and connect with those community infrastructure that can make a difference.
Charlotte, this points to me in a direction about trust and relationships and trusted communications and trusted relationships. What are the core elements that we should consider if we're thinking about planning our communications, as Mukesh has just said, about where that trust comes from and what those relationships are founded on?
Well, again, I agree completely with what we've just heard, and it sounds like we're almost hearing again the importance of, it's not just what's said, but it's how it's said, and it's who says it as well. And one of the central challenges, I think, of more public health level messages that are government led is that the person that's delivering or the people that are delivering those messages are often people that not everybody trusts, because fundamentally it's linked through to politics. It's inseparable from politics. And therefore what we have as well, particularly in terms of the pandemic, is that public health messaging is often very closely linked with economic considerations, for example. And sometimes the two are not very supportive of one another. If anything, they're mutually exclusive, because, for example, asking somebody to shield and asking people to stay at home in a lockdown is at direct odds with supporting a flourishing economy, for example. And the government have got a very, very difficult task, I think, of trying to manage these conflicting messages and conflicting ideas. However, the way that we navigate that is through modelling behaviours that we'd like to see in others. So we've seen lots of examples in government, I think, that probably just serve to add to the confusion and add to the lack of trust and respect of the messages. But for me, I think when we're talking about health behaviour and we're talking about behaviour changes, it's always extremely difficult to do that at a population level when we consider that actually it's those individual values and individual differences that often drive our decision making. But I do feel that storytelling, as we've just heard, is a really, really useful way to help people explore and understand their own feelings of ambivalence about engaging in a particular health behaviour or not. And vaccine hesitancy is a great example of where something like that might be relevant.
Charan, what has been the most impactful and positive communication or moment, I don't know how to describe it, in terms of the Punjabi community? What has driven, I mean, Mukesh described about his kids, you know, kind of, Dad, you've got to think about this. Is there something that you can point to that kind of says, yeah, this is where the take up of social distancing and now the vaccine has been boosted in the Punjabi community?
Yeah, well, what I'd like to do, if I can just come back a bit from that a minute, Rob, is first, you know, what I've seen is that signposting people with health issues over the last decade or so has really moved on and it's improved. But when you get a pandemic, all that, you know, it's not there, it's not relevant. People can't go into doctor surgeries to see what leaflets are on the wall. You can't visit the pharmacist or a health centre or a community centre to see what's up on the wall. The place where you can get communication from really is going to be videos, like Mukesh has mentioned, the TV and audio, such as radio or podcasts. So it's very important that in the future, any practitioners that, you know, do look at how we're going to get the information across. Everywhere was closed. There was nowhere else you could get information, apart from places like community media and TV. And yet the authorities were reluctant, for whatever reason, to approach these people. They were busy preparing leaflets, but when a leaflet drops through your door, who's actually going to read it? And like Mukesh said, even you know, people who've been here for the last 30, 40 years from the BAME community probably can't read those languages anymore or aren't proficient enough to understand those languages. So that was the first thing. But in terms of what we've seen that's improved, it's a difficult one because so much has happened throughout the past year. But I think the main thing that came across was the number of people who were actually getting the infection, the number of people in Leicester who were dying. We actually ran a 3 hours every morning program just discussing the virus, and the number of people who rang up actually with their stories of people who had passed away in their families within the last few days, and urging people to look out for these signs, that this is what's happening, this is where they picked it up, you know, whether it's from a child who'd been to school and come back when schools opened in September. I remember one story we had of a presenter who'd actually heard on their show and came back basically crying to me in the office, saying, I've had this family on, and a 9-year-old boy came back from school with the virus, which he picked up from a school bus. He knew people were coughing and explained to his parents. Within a week, the parents and an 18-year-old sister and a 6-year-old brother had all had the virus, and all 4 were taken to hospital. The younger child, the 9-year-old, was then taken to the grandparents, stayed with the grandparents, and it was actually the grandfather who phoned in. And he then phoned a couple of weeks later saying all 4 had passed away. Gosh. So it was a very, very sad story, but it was things like that which I think the community were listening to and actually taking note. And it was after that I felt that there were turning points with such interviews like that from the community, which was actually frightening people to actually stay at home. Whereas during the first lockdown, I think you're probably aware of it, Rob, I did come out in the local media to say that people were not staying at home. People were going into work, the local factories were open, and the virus was spreading. And that was due to lack of knowledge. But when information from the person out on the streets coming across, from families coming across as to how devastating it was, I think that was the turning point.
It's kind of almost as if the assumption-driven media, the mainstream media, has avoided the pain and the trauma of this process and the anxiety. And because people have maybe recoiled, I know Ofcom did a lot of one of their surveys. Their surveys indicated that people stopped listening to news channels because the anxiety, the information overload that it created. Charlotte, in terms of your, if we're sitting planning for an approach which doesn't, which we've got this multifaceted thing, haven't we? We've got to give people information, but we've got to do it in such a way that it recognises the experience that they're going through and what makes it meaningful to them. But also we've got to put it in a context in which it doesn't hide away from the facts and what has taken place. How do we communicate on that level with people? This is where we go beyond just instructions, and we're looking at something which is more deeply meaningful. Is there anything from a psychological model that would go past those assumptions and into a more rounder, fuller picture of people's needs?
Sure. The British Psychological Society have actually produced some fairly helpful guidance for public health practitioners mainly, but anyone who's in the business of communicating health messages during the time of a pandemic. And if you just Google that, anyone that's interested will be able to find that guidance as a fairly brief PDF document. So in there, you'll find some top tips related to something that we kind of touched on earlier, which was around the trust of messages and the trustworthiness of messages in terms of, well, who is it that's communicating that message, and therefore how accurate and how relevant is it likely to be. So if we're getting most of our messages, for example, from social media, where it might be that somebody's very misinformed or extremely anxious about a particular aspect of the pandemic, like the vaccine, for example, then it's likely that actually what will happen is that just translates into ill-fitted, inaccurate information. And we've just heard that there's nothing like word of mouth for translating information quite rapidly. And if that information's inaccurate, there's a real challenge there for the professionals to communicate more accurately and to build that trust and compassion with populations again when that level of inaccuracy is in circulation. But I think for me, the very difficult task for people who are communicating a lot of sensitive information is just that. It's how do we communicate more compassionately and sensitively, and how might we utilize key theories in psychology that tells us a little bit more beyond behaviorism, although behaviorism might play a part in it. But in addition to that and beyond that, there's a wealth of psychological theory that helps us understand what kind of things tend to influence behavior that is potentially quite underutilized. But as someone that has always campaigned, I think, for avoiding an over-reliance on theory at the expense of skills, because I think really passionately it's important not just to think about what's done, but how it's done, so both the knowledge and the skills. I'd suggest that what might be helpful in terms of answering your question is a really good balance between accurate evidence-based theory, psychological theory, but that's well translated into the how-to as well. And that's got to be culturally sensitive, it's got to be population sensitive. And some of that is related, I think, to the notion of compassionate communication. It's accurate, yet it's compassionate, it's relatable. It's all that good stuff that we know gets people's attention and builds trust and elevates that sense of motivation to want to do something about whatever the challenge is, in this context, COVID-19 health behaviours.
Mukesh, in terms of that compassionate dialogue and having it's about shifting and changing the communications model from, I kind of, it's like a transactional model, as I think Charlotte described this really well earlier, or actually yourself described it, in terms of most people have gone through a mass media marketing comms course, and it's a one-way production process. You deliver a message to people. We still think in terms of transmission of messages and not relationships, founding of relationships. That storytelling process that we've talked about, what is it what do we need to do to convince those people in the comms department to embrace that two-way dialogue storytelling approach?
So I guess the first thing is that you can't address an issue until you identify it and understand it. So with having that mono aspect of, I'm a communications lead, my training is communications and marketing, and yet I'm trying to resolve social perspectives in community work, or I'm trying to address cultural values and traditions, because you're not going to get that within your marketing communications training module. Now, when these people are sat in their communications departments, they're not talking to their colleagues in the community engagement team or the youth work team. They're not, the NHS engagement leads are not talking to public health colleagues in the council. And what's missing, therefore, is that strategic networking where you start looking beyond the one-off approach, i.e., oh, we've got vaccine hesitancy, what are we going to do? We'll put some posters out. No. What they need to do is say, okay, let's get a multi-agency, multi-stakeholder discussion going and say, this is not one of those things like, the winter flu. It's not going to be around for a month and a half and disappear. So how do we have that dialogue with community workers, health education campaigns, with voluntary community organizations? There are so many charities out there, that we're not engaging. Academia, De Montfort University, Leicester University, how do we bring local authority, health and social care, all of these things together and say, right, okay, this is not, Charan, you said it earlier on, it's not a one size fits all. We have to adapt to the target audience. Now, when we say BME as an example, we could be talking about LGBT or disability or whatever, or young people, that you have to make the process aligned and relevant to the target group. And in order to do that, you need to find a bridge between professionals and the target group. Now, unless you're doing community outreach work, or you've got radio station, or some sort of social media activity or something, you need to find a bridge between the service providers or the experts, so-called experts, and members of the community. And so I think, the missing link here is having that strategic planning where you say, let's have a 3-year or 5-year strategy, which brings comms, community education, community outreach work, partnerships, networking, all of those things together with those sort of champions within the community that are not self-elected, self-elected leaders, but people that are doing it for the community out of their own goodwill and commitment. And that could be, radio stations. It could be religious leaders who have influence. It could be people that are doing voluntary work every day, bringing food parcels to people's homes or ringing somebody up who's frail and on their own. Those are the real champions. So how do we bring that together in some sort of a structure? So far, I've not heard any discussions around that model.
Let's just for a moment, I'm going to kick this ball to Charan. If you were in that multi-agency room and the discussion was, as Mukesh has rightly said, what do we do? What would you say the role of community radio is in, what does it offer as part of this set of solutions?
I think there needs to be some kind of, I would say, a media advocacy toolkit in the sense that the people who make these strategy decisions learn how to communicate with people for a start. I think the communication at every level is quite poor. I'm going to give you an example without mentioning any names. 2 months ago, I was approached over a phone call from the local health authority if we could run a campaign to promote vaccinations amongst Punjabi people. We were given a script which I translated into Punjabi, and I sent back 4 times to 3 different offices. Firstly, they couldn't open a simple MP3 attachment saying their computer software wouldn't to take anything like that on board. And then I heard that somebody had gone on holiday, the other person had taken leave, somebody else was off sick. Like there was no real buy-in at all. It was like it was a procedure they were going through without any real interest whether it actually got completed or not. And now, 8 weeks down the line, we still haven't received any feedback from what we produced 6 weeks ago. As a result, we've actually gone ahead and done something ourselves just to try and promote the vaccinations. But what we can offer is a platform for health professionals to come in on a regular basis, because when you're in a pandemic, it's not just something which is a snapshot. It doesn't happen on the 14th of May, and then for the rest of the year, nothing's happening. It's got to be a continual process so we can change people's attitudes, change people's understanding and their behaviors. What we could offer is somebody to come in on a weekly basis or on a daily basis to actually engage with the community, give out the message, give out the information, but then open the lines for the whole day for 2 hours, 3 hours to take people's views on board. That is very important to actually have a two-way communication, which is what we're finding here, that the communication we give out to people are responding. Why do we have to do this? If we do this, what's going to happen? If we don't do this, what's going to happen? Whereas what we've seen here is that we try to get a message out across to the general community, but I'll give you the example of the people who were working in factories during the start of the pandemic. Now, the message I was trying to get out across, people trying to get across is, look, these people don't fully appreciate the seriousness of what they're doing by going into work, by spreading the virus, by coming in contact with the people when everyone's told to stay at home. That message wasn't taken on board by the authorities. The message was taken on board more like the people responsible for work, for immigration. There were raids on factories, right? There weren't health professionals going there. They were looking at the working conditions, looking at the pay, the health conditions in the factories. So immigration at the factories, the whole remit, which was supposed to be about the pandemic, it had totally been forgotten. It had been hijacked. That sort of needs to be brought back into line. And what we do need to do is look at the platforms across the city and see how we can use those platforms effectively. Here at Kohinoor Radio, we are just one very small platform. But like Mukesh has mentioned, there are various other channels that we can use. Social media. What happened with social media was it was all the negative people putting out negative information. We're getting information across, Whereas the authorities were very slow getting information across about the vaccinations. So that is the part which I think we certainly need to improve. We have a platform ourselves, and there are other platforms throughout the city which I seriously would like to see being used.
Charlotte, this media advocacy toolkit approach, I fully endorse. I think that would be a great idea. What in putting something like that together, what would get the buy-in from people? You know, if there's a communications hesitancy to embrace this, you know, compassionate, dialogue-based, community-focused form of communication, that's where the hesitancy is, I think. Not necessarily in people themselves, but it's in the communication system. But what would get buy-in for that kind of approach?
Perhaps one of the biggest sources of evidence for sort of prompting a healthy level of buy-in would be the impact of the current approach. It doesn't appear to be working, or it might only be working for a certain population of people, or a portion of population of people, and therefore there's nothing better than it's not working to tell us that perhaps we need to be doing something differently. So for me, I guess fundamentally it might be around helping people to understand and appreciate the poor level of impact that the current approach has to engaging people better, and to, in terms of healthcare, trying to generate better outcomes for people and populations and families.
So, Mukesh, you're kind of thinking and planning about this for the future. What's changed? What have you learned? And what are you shifting direction? Are you shifting emphasis as an organisation in terms of how you approach this? Are you more tolerant? Are you less forgiving? What's the way that you're going to play it out?
I think the first thing is to learn through successes and mistakes. And one of the things that has been a learning factor is that, you know, the one size fits all doesn't work. It needs to be a bespoke model to each, not just each community, but to each situation as well. And one of the issues is that, you know, even going beyond, you know, way before COVID, there have been so many consultations between, you know, the public sector or mainstream, for want of a better word, where they've gone into diverse communities, said all the right things, and then never come back to the community. You know, so the communities feel like, you know, they've been ripped off, you know, used, that kind of thing. So if you're talking about building rapport and trust, you need to maintain that and keep it sustainable. Doing that within a model of reflection and learning is to provide some infrastructure where you might get some sort of grassroots platform where you get the right people involved, and you start from the beginning by saying, okay, look, what are the issues? And just have an open book without an agenda, which is limiting discussion. And it might take a little bit longer, but at least people have a chance to say, well, we think this and we think that. You then forge a framework and you say, okay, who wants to be involved in taking this forward? And then you get that independent, community-grown, grassroots proposal that goes back to the service providers and says, right, okay, this is what we're saying needs to happen. And it's going to address not only today's issues, but the longer term issues about how do you communicate, engage, but also involve different communities and take account of all the changes that happen over different generations. Now, this is, I suppose, we're touching on, you know, social perspectives in youth and community work, and, you know, social construct and all those sort of things. But you've got to start somewhere by saying, okay, you know, how do we really talk about common purpose from a grassroots perspective, not from the mainstream providers, because the mainstream, although the intention is good-willed, they've got a fixed agenda. You know, they want to meet a target, or they want to meet a deadline, or they've got government pressure to say, oh, Leicester's high on the COVID ratings. What have you done about it? So there's a bit of panic there. There isn't this thing about building rapport, trust, confidence. You know, when we talk about producing publications in the mainstream, let's say for example, the local authority or the NHS, we talk about making it plain English, de-jargonate it. So when we talk about translating into different languages or having that communication, the same thing needs to happen. I'll give you a very quick example. Only about a month and a half ago, we were talking about the Somali community. And we had two members of the Somali community who work very closely with me. And we were talking about translations. The City Council were having a debate about the correct translation into Somali. Now, we've got one person who advises internationally in terms of Somali languages, and another person who's got an OBE. And they're going loggerheads with this City Council translator who's based in Manchester somewhere. So in the end, they said, oh, Mukesh, can you help us out? So I said, okay, let me speak to this individual. And I said, look, the translator was talking about the formal Somali translation, a bit like if we were saying, you're going to translate it into the Queen's English, English grammar. It's not going to work in Beaumont Leys or New Parks or, any local area. What you want is the language that is spoken in the community, in the households, as opposed to the formal language. And that was the issue in this discussion or debate in the Somali language. So although the translator was correct in terms of their Somali grammar and translation, the right way to go was what the local people were saying.
It beggars the question, why is the translation not done locally, with somebody who knows the area? So, Charan, what's the advantage of community radio in these terms then, and particularly community radio that's based within the community that it serves?
The advantage of, I suppose, community radio is you'll have not just one or two messages going out across to people. It's a different message every day. For the same purpose. Like every presenter who will be on will be talking about the right things to do during a pandemic, what to avoid during a pandemic, and how to look after people, your family, your friends, and also the community at large. And it's a question, I personally feel, it's a question of developing relationships. When we have relationships with our family and friends, we can help them. And it's the same level that although the authorities say, yeah, we want to develop relationships with the community, they haven't been successful. And until relationships are developed and the communication is two ways, it's going to be difficult to see how we move ahead.
Charlotte, what would be your recommendation for how those relationships are best established?
I think we've already heard it in a way. The fundamental challenge, I think, to anything that involves trying to gather evidence about what works best for people is that sometimes the model that's used to do that is ill-fitted. So we'll see, for example, in research that comes out of universities that's really good, robust research, it doesn't translate well into practice and communities because it's not been delivered with communities and with people as genuine active participants in that process, from very much a kind of participatory and co-produced methodology. And we see the same in healthcare. We see that, a fantastic approach to managing long-term conditions, for example, in primary care might be suggested. But the reality is that sometimes it's just not feasible, because what's happened is that the research has come out as something called a randomized controlled trial, which means that it's been controlled for within an ounce of its life. And then you try and translate that into messy practice, and practitioners just can't deliver it in that very clean and manufactured way that it's been assessed in the research context. So really, I think the key for this is that two things that we've already heard. One is that, this is more about a process rather than an event. It's about an ongoing process. and it has to be genuinely co-produced with the community at its heart. And dare I say, it sounds very cheesy, but it has to be, you know, with the people, for the people. Otherwise, we're constantly going to have this issue of trying to translate what looks like good practice and good messaging approaches into an environment that just doesn't fit right, because it hasn't come from the people, for the people.
I was going to ask you if you could give us a kind of sum up, but I don't think I'll go any further than that, because that was great. Mukesh, in terms of a kind of encapsulation of what would you know, we've really identified what we'd abandon, what we'd leave behind. But what would you keep? What have you learned from the experience of going through this last year that you'd maybe keep and want to retain?
I think the partnership working has to be the way forward, or should we say collaboration, and that needs to extend beyond the service providers. What I'm talking about here is where we all work together, like Charlotte was saying. I very much would like to see the creation of a community communications charter, where we get a sign up from the voluntary sector, the media, the health professionals, and like I said earlier on, not just the communications leads, but the community outreach or community engagement specialists. You know, let's have an event, let's have a summit on community communications and involvement. And that leads to that discussion. It should be more than a one-off, as you said, Charlotte. It should be a series of workshops or, you know, breakout groups and case studies that leads to a charter that we all sign up to, that says we will commit to doing X, Y, Z. And we can then be held accountable to the communities to say, this is what we are proposing through the discussions we have on, you know, with your involvement and support. And this is what we feed back to you in terms of where we're at with progress. These are the outcomes, and this is what change looks like. It's only then that we'll get the confidence, trust, and rapport that overcomes some of the previous experiences that we've heard about, where the communities say something to the radio station, and then the council changes it to their own advantages and tick their smart objectives and things, and it's been hijacked, I think was the word you used. Yeah. So we have to re-own the communications and say, look, yes, you are a service provider, but it's our health, it's our lives at risk. So we want to be able to influence the key messages, and one of the key things that I've learned, which, with hindsight, I would have done last year, is I would have put more information out about what services are available, which services changed, and get feedback from the public in terms of what they want to see kept and what they want to see gotten rid of. And we're doing some work at the moment about people's experiences with GP practices and online appointments, as opposed to, waiting on the telephone for about 20 minutes to get a reception to pick the phone up. So there's a lot of work to do, but I think that the only way we can do that is to have that community communications charter.
Charan, last word to you. What would you gladly abandon, and what would you fight to retain and embrace?
In terms of what I would like to see happening, fight to embrace would be a multifaceted approach to communication. We really do have to look at that very carefully and make sure the communication is tailor-made to specific communities and people, individuals, and that will only be achieved by listening to them and looking at the appropriate channels of how we can get information across to them.
I think the technology, the Zoomification, if we can call it that, has really, one of the things that comes out of this whole process, that has maybe we're able to do these kind of discussions and share them as well. So that might be one of the positives that come out of this, that it opens up the process of conversation and discussion. It's been really fantastic. I've written about 5 pages of notes, which is always a good sign. So just to thank you again, Mukesh Barot, Charlotte Hilton and Charan Johal. I'll post the links to each of you to on the blog post that goes out with this. And if there's any other discussion that people want to follow on after this, the Germ's Journey website is germsjourney.com, and you can follow on Twitter and Instagram at Germ's Journey. But until next time, thank you very much.
Thank you, everyone.
Pleasure.
Never to meet you all.
This has been a Germ's Journey discussion, a conversation about the importance of public health communication. To find out more, visit our website, germsjourney.com, or follow us on Twitter and Instagram at Germ's Journey.